Hello, everyone, and welcome to the Melanoma Research Foundation's What's New in Melanoma Management, an educational symposium for patients and caregivers. My name is Debbie Churgai. I am the Senior Education Program Manager at the Melanoma Research Foundation. We are pleased to have you join us today for this wonderful educational opportunity. We have some amazing speakers today, so I'm going to first start out with a short intro about the MRF, and then we can begin the program. Before we begin, I just want to mention that we are hoping to have time for Q&A after each presentation. So throughout the program, if you have any questions, please either use the Q&A button, which should be found at the bottom of your screen, or you can put your questions in the chat and we will try to get as many questions answered as possible. First, I want to thank our sponsors, Castle Biosciences, Pfizer, Genentech, Iovance, Bristol Myers Squibb, Merck, Immunocore, Amantix, and Regeneron. These amazing companies have sponsored not only this event today, but several other of our patient symposia events and webinars throughout the year. And we could not put on events like this without their support, so we're very grateful to them. I'm going to start out with just a little intro about the Melanoma Research Foundation. The MRF is the largest independent organization devoted to melanoma, committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. The MRF also educates patients, physicians, and about the prevention, diagnosis, and treatment of cutaneous melanoma and the rare subtypes, including ocular, mucosal, pediatric, adolescent and young adult, and acral. The MRF was founded in 1996 by Diana Ashby, who was diagnosed with melanoma, and after a 3-year battle found that there were no options for new therapies and clinical trials. This is a picture of Diana and her husband, Captain Jeff. Diana's legacy lives on through the MRF and all the incredible work that we do to accelerate medical research while educating and advocating for the melanoma community. The MRF consists of 3 pillars, which are education, advocacy, and research. I am the Senior Education Program Manager at the MRF, so I help with all the educational opportunities, and this webinar today is an example of one of our amazing free opportunities that we offer for patients. And I'm just going to go through just a few more. The MRF has created over 30 pieces of educational literature available for free to order for clinics, schools, community events. Topics include cutaneous, ocular, mucosal, pediatric, as well as youth prevention and clinical trials. We also host monthly Ask the Expert webinars, and we have 6 animated patient videos, 3 more in the works. These videos are all less than 10 minutes long and offer a lot of information with great visuals. And if you were looking for more educational content, please check out our YouTube page. We have over 100 on-demand videos that can be found there, as well as all of our past patient symposia, like the one today. We will be posting on YouTube in about a week or 2. So if you miss anything today, you can catch it on our YouTube channel. And all of our past Ask the Expert webinars are also on there. We also host a patient community forum. Conversations include a range of topics such as new therapies, rare subtypes, how to handle grief. The community forum offers a great place for patients and caregivers to connect with others or to seek answers to questions they may have about specific topics. I want to introduce our newest program called SunAware. SunAware is a safety e-learning educational curriculum for children. Students in K through 5th grade are encouraged to build healthy habits that prevent melanoma, skin cancer, and sun-related skin damage. This program is completely free, and we are currently conducting outreach to bring SunAware to schools across the country. If you are interested in learning more about SunAware for anything you have going on or your children's school or anything like that, please check it out on our website. It can be found under the education tab on the MRF website. Research is at the heart of our mission, supporting scientists whose discoveries lead to better treatments, improved outcomes, and new hope for melanoma patients. This slide highlights some of the groundbreaking research the MRF has funded in the past and continues to support. We have awarded 33 grants in 2024 and have funded over $26 million in research, and that number is very likely to increase next year. Another facet of our research is our Breakthrough Consortium, which you can see MD Anderson is part of. This consortium accelerates melanoma translational research through multi-institutional collaboration and fostering the growth of early career scientists and clinical investigators. As I mentioned before, we also advocacy is one of our pillars. And every year we bring patients and caregivers to the Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer and specifically melanoma research. If you would like to attend our advocacy day next year, please reach out to me and I can give you more information about that, which is going to happen on March 1st through 3rd, 2026. We have several prevention and awareness campaigns, including Get Naked, I Get Dilated, which is about ocular melanoma, Out of the Shadows campaign focused on mucosal, and our Spot the Dog campaign, which is pediatric melanoma awareness. We also host nationwide series, 5K run walks known as Miles for Melanoma that allow participants to support and raise funds for the MRF by coming together in their community alongside fellow melanoma patients, survivors, caregivers, and supporters. We actually have one going on today in Fort Myers, Florida, and we have one in February, 2 in February, and next year's dates will be coming soon. So please keep an eye out if you're interested in joining us at one of these events. There are a lot of, it's a good time. You can bring the whole family. There are many opportunities to support the work of the MRF through a variety of programs and events, research funding. So if you're interested, please reach out to education@melanoma.org to learn more about ways you can engage in melanoma community while investing in our shared mission. And lastly, the best way to learn more about the MRF is just to follow us on social media. You can learn all about our education, advocacy, research programs, awareness campaigns, everything that I kind of mentioned. After this program today, I will be following up with a survey. If you could please just take a few minutes, I promise you, it's just a few minute survey. It really helps us kind of improve future programs and sessions. Again, I want to thank our sponsors one more time. And now we're going to start the program. Now, our first speaker today is our patient speaker, Murray Keith Wadsworth. While staying vigilant with routine screenings for potential prostate cancer reoccurrence, Murray was unexpectedly diagnosed with a melanoma liver metastasis 7 years after his upper back wide local incision. He has now completed 15 of 24 scheduled Opdivo treatments and has shown NED status since his 3rd infusion. A full-time RVer, Murray receives much of his care on the road, continuing regular blood work and treatments during what he calls his RV immunotherapy road trip. Murray is the creator of sheeporwolfcancer.com, home to his book, Prostate Cancer, Sheep or Wolf, Navigating Systemic Misinformation, and his podcast, Prostate Cancer Lessons. He has written for numerous publications and has been featured in both print and podcast interviews. And we are very happy to have Murray today. And I do want to mention one more time, if you do have questions, please put them in the Q&A because we did ask Murray to leave a few minutes just in case anyone has questions for him. So Murray, thank you so much for being here today.
Oh, good morning, Debbie. Thank you for having me. Are we on?
Yep.
Okay, great. It's quite an introduction. Thank you. I'm a bit humbled just for a moment. I'll start here at where I think all of this should really begin, and that is your Get Naked campaign, which got my attention some time ago. Screening has been crucial to me with both of my metastatic cancers. for both early detection, which is clearly a key, and I continue on with extensive, uh, what I will call screening after diagnosis. And as you mentioned, that's how I stumbled into this metastatic mat. So to share what happened is in 2018, I did have the surgery on my back for the removal of the melanoma. The margins were clear. The sentinel lymph nodes were clear. We began the semi-annual checking of my back with dermatologists to make sure it was not recurring. And as each year progressed, we felt very confident that we had all of the cancer. In April of last year, I got a routine liver MRI. I also have, as a side issue, hemochromatosis. I carry the genetic genes, although the disease is not active, so we watch it carefully. I'm very fortunate there. And the liver MRI was clear. In July of last year, I had my next round of PSMA PETs and liquid blood biopsy testing, checking for the potential of lingering prostate cancer. I am now 8 years NED for prostate cancer, but I keep a very, very close watch on it. And that imaging brought up a growth in my liver, possibly a cyst, was the report from the radiologist. So I kind of gave it some thought. I was up in the woods, actually in Idaho, when this happened. And then a liquid blood biopsy result that I had done came in. And that came in with the TP53 mutation, which is in fact cancer, not of known origin, but unequivocally cancer, circulating tumor DNA in the blood. This is something I self-drive as a patient. So that spurred another MRI of the liver. And in 3 short months, a 2 centimeter melanoma tumor had appeared, is what we realized post the biopsy. So I packed up my bags in Idaho, like you do when there's a forest fire. You leave camp quickly, and got my way down to Houston and started to make my appointments with doctors. And we began the duplet immunotherapy as quickly as we could. After 3 months, did the scheduled imaging, and that was no evidence of active disease. We still had what looked like the tumor in the liver, but it looked inactive. It was smaller than original, and the liquid blood biopsy was clear. So this was incredible, fantastic information. We were very, very excited. 3 more rounds of the infusion of the immunotherapy, imaging again, this time with MD Anderson, and another liquid blood biopsy, and they are clear again, and the tumor is further reduced. Carrying on with my immunotherapy out on the road as I travel in the RV, up to the 15th treatment and 1 more round of imaging. And now there's no trace of the tumor in the liver. And the liquid blood biopsy is again clear. So that's how quickly all of this has transpired. And I am one of the great fortunate ones to be benefiting. And we are in a state now of evaluating what to do next. I just, as you know, I just came off a cruise, and that sounds crazy to have done that. If you're a melanoma patient, I'm down in the sun in Mexico. But part of what I was doing, if a friend of mine had a free upgrade and a free room, he's a often cruiser, and his wife couldn't make it. So I was celebrating the very good news that I have, and also beginning the discussion with myself of, do we carry on with the treatment? That is a discussion now that is rising. Since I am continuing to show no evidence of remaining disease, do we consider at some point discontinuing the treatment, taking a risk in that, but also no longer needing the treatment? Or do I carry on? And it's a very personalized decision, one you make with your doctor, but it's still deeply personal. So I gave that a lot of thought. And the decision I've made on this trip is I'm going to carry on for another 2 months and have 1 more round of imaging and 1 more liquid blood biopsy, and then I may make a decision if I'm in good shape, because so far I've been very fortunate to have no side effects from the treatment. Um, Going over a few other things, since that's sort of the quick run, I have not had, as I mentioned, side effects of any significance other than I sleep. I can sleep 12, 13 hours a day. which in many regards is wonderful, but then it also takes away half of your day. And so you have to sort of readjust your life. I've also not had any rash problems, which are very, very common. And again, I cannot be grateful enough. But what is interesting, I can't prove anything by this, but in the first 4 months of the treatments, I swam almost every day for more than an hour in a saltwater pool. I did saunas and cold dips. And when I'm in the mountains, I do cold dips in the streams. And I do a tremendous amount of walking, 4, 5, 6 miles a day and more. I was walking on the cruise ship every day. I don't know if all of that or any of that helps, but I certainly like what I experience in terms of not having the side effects. And so I'm just going to say that is from good fitness and some of the other activities that I do.
All right, thank you so much for sharing your story. I don't see any questions, but I want to know if you have any other helpful tips for patients or any final thoughts that you want to share with people about your very unique journey.
Certainly, going back again to your Get Naked campaign, the importance of screening, whether it be prostate cancer or melanoma cancer. I found my melanoma that was on my back. I was up camping in the mountains and using mirrors. I could see the spot, but I took about 6 months to do anything about it. Now that we know that that cancer has spread, did I wait 6 months too long? We can't answer that question, but that now has taught me to be more responsive to skin concerns. And I move much faster now on any concern that I have with getting to dermatologists, and I have them positioned in several states. Although my primary dermatologist is with MD Anderson now, but on the road, I get things done. And I've noticed a difference on the road, and that is I get different opinions from different doctors. And I actually had a what turned out to be a grade 0 melanoma missed by two dermatologists and then picked up when I got back down here. Unfortunately, it was grade 0, but it was in fact a melanoma cancer. So my biggest share is the need to do the very, very thorough screening. And then my other favorite comment is on the liquid blood biopsies. These are relatively new. They're being studied for their benefits, but I was using these with prostate cancer. Part of the thinking is that they identify the presence of cancer in the bloodstream before imaging does. So that's their value. And that finding that I mentioned, the T53 mutation, is what triggered me to move very quickly to a biopsy to realize I had metastatic melanoma in my liver when 4 months prior, I had nothing in my liver.
Wow. Wow. Yeah, I appreciate you sharing that message, sharing your story, and encouraging people to get the screenings. We also, as I mentioned, MRF does those 5K miles for melanoma events, and we always have free screenings available there because we want patients to be able to be encouraged to get those screenings to find issues like you did. And thank you so much for being here. I just want to say Murray was on a cruise just yesterday. I mean, just this morning, he just got off his cruise and he was able to rush home just to be here in time for this webinar. He talked to me while he was on his cruise. He took time away from that. So you are amazing. Your story is amazing. I encourage everyone to check out his podcast and book.
Kind of you.
And yeah, thank you so much. And hopefully please stay on the webinar if we have any other questions.
Okay. If I could say one thing,
Yeah.
one more thing, 5 days on the boat in the sun and not a trace of sunburn. I'm very, very careful. I got too many sunburns in my youth, being raised in Southern California. So I can get out in the sun and not get sunburned. So we don't have to be completely afraid of the sun.
Oh, I'm
Murray,
sorry.
there's just
Oh, yeah.
two quick questions that are coming for the audience. One is somebody wanted to ask you what was the blood test that you had that detected the P53 mutation, and they also wanted to know which immunotherapy that you're on.
The liquid blood biopsy testing that my hematologist is using is the Guardant 360, and I was using that mainly for prostate cancer, and I had two annual tests of those. They were clear, and then it came out with the TP53, which led to the immunotherapy. And I did the duplet, the Opdivo, and the Nivo.
The Opdivo and the Yervoy.
Yervoy, yes, thank you. Sorry.
Yep. Yep.
I just got off a cruise, so give me a little slack.
Not a problem. Not a problem. Absolutely. Thank you so much, Barry. We really appreciate it.
My pleasure. Thank you all.
Thank you. And now we are going to go to our next speaker, Dr. Michael Davis. Dr. Davis is professor and chair of the Department of Melanoma Medical Oncology at the University of Texas MD Anderson Cancer Center. He is a physician scientist who has led clinical trials of immune and targeted therapies for patients with melanoma. His research has encompassed many areas, including the role of oncogenic signaling pathways in cancer, particularly in the therapeutic resistance and CNS metastasis. He has published more than 280 peer-reviewed original research publications. He is the former president of the Society for Melanoma Research, and he is an elected member of the American Society for Clinical Investigation. And we are so honored to have him here today. Thank you so much, Dr. Davis. He has been such a great help getting this symposium together. Thank you so much for being here today.
Thank you so much, Debbie. I really appreciate it. And let me move over to sharing my screen. So good morning, everyone. Thank you so much for joining us. Thank you again to the MRF for your support, and again to the sponsors. And so my job here is to give you sort of an overview of what we're going to do today. These are my disclosures. As someone who does both clinical research and laboratory research, I do work with many different companies about how do we make their treatments work better. And just stepping back, as I'm sort of our first of the scientific speakers, is to talk about what really our goals are for today. And that's really twofold. And one is to really talk to all of you about some of the exciting advances that have occurred in melanoma patient care and research in 2025, and in particular, then saving some time for your questions about them. I will say that my presentation is really meant to be an introduction, and so we're going to go from mine to the other talks, but we've also reserved time at the end so I can answer questions either about what I've talked about or about what any of our other speakers have presented. Now, just to make sure we're sort of all on the same footing, I wanted to start out with just some basic slides about melanoma. And so what is melanoma? And so melanoma is a type of skin cancer. And it's actually not the most common type of skin cancer. By far, the most common types of skin cancer are basal cell carcinoma and squamous cell carcinoma. And so melanoma represents only about 10% of the skin cancers that are diagnosed here in the United States every year. However, this is the skin cancer that has the highest risk of spreading to other parts of the body and to being a lethal disease. So while basal cell carcinoma and squamous cell carcinoma are usually cured with surgery, melanoma is something where we really have to be concerned about the chance of it spreading to other places in the body. And I will say, when we talk about melanoma, conventionally, we're talking about melanoma that starts on the skin. This is by far the most common type of melanoma, but there are melanomas that can start in other parts of the body. These are much more rare, and they're not really the focus of what we're talking about today. But as the MRF has sort of talked about, these are things that, again, we are making progress on, and we'll be happy to answer some questions. And that includes mucosal melanomas that start on mucosal surfaces in the body, and uveal melanomas that start in the eye. So when a patient's been diagnosed with melanoma, you'll often hear your doctors talk about what stage of melanoma you have. And this is actually for all cancers. We really have these staging systems that help us group patients together, both to help talk about what their prognosis is and also to say what are the appropriate treatments. And so as in most cancers, we have 4 stages for melanoma, stages 1, 2, 3, and 4. And so what's shown on the right is they kind of put these in order. So a stage 1 melanoma is a cancer that is present in the skin. And it is, by definition, a tumor that, based on its characteristics, has a very low risk of spreading to other places. And so the standard of care in terms of how we traditionally treat these tumors is surgery to remove them. And then based on what we see when we remove the tumors, we may do what's called a sentinel lymph node biopsy to see if there's any evidence that the cancer spread to lymph nodes nearby. But that's not done in all of these patients. It's done in a select group of patients that have certain features that suggest there's a higher risk of spreading. Stage 2 melanoma is our next stage, and this again is still melanoma that is only in the skin, but now we see features that suggest that there's a higher risk of the spreading to other places in the body, such as a thicker tumor or having ulceration. For these patients, we again still do surgery to take out that primary tumor, and then in most patients, we offer a sentinel lymph node biopsy, a procedure where we sort of determine if melanoma was going to spread, what are the lymph nodes it would be most likely to spread to? We then remove those lymph nodes and look under the microscope to see whether there's evidence of cancer in those lymph nodes. And so that gets us to stage 3. So stage 3 means that the melanoma that started in the skin has now spread to things that are close by, most commonly to the lymph nodes, but we can also see what we call in transit disease or satellites that are really sort of, again, moving along the way radially out from the tumor. So again, things that are close by. And again, historically, the way that we've treated these tumors is by surgery to remove not only the primary tumor, but also the lymph node metastases. And because these tumors have now a higher risk of spreading to other places in the body, we usually talk about doing adjuvant treatments. And these can be medical treatments, these can be radiation treatments. And those are all designed to try to prevent the cancer from spreading to other places in the body. What you'll hear about a little bit later is a new approach for patients with stage 3 melanoma, which is neoadjuvant therapy, which refers to us doing treatments not after the surgery, but actually doing treatments before the surgery. And you'll hear more about why we think this is such an important new approach for these patients. And finally, stage 4 melanoma means the melanoma has spread to distant places in the body. This is not something in general that we can cure by surgery alone, because the cancer has gotten into the bloodstream and can be at many different places in the body. And so here we usually think of the primary approach that we're going to use is actually to use medicines that can treat the whole body. Now, we do sometimes use surgery and or radiation when specifically this is needed to help in specific places, such as tumors that are painful, or sometimes we have patients that have just 1 or 2 tumors and we can remove them, and we do think about using those local approaches. But overall, this is again a setting where we're usually trying to do treatments that will treat the entire body. All right, so we historically didn't have good treatments for patients with melanoma. And indeed, when I went through my training, and the picture in the upper right shows me in 2007 when I graduated from fellowship and joined the faculty here at MD Anderson. And this was sort of around the time when we had done our staging system to estimate how patients did with stage 1, 2, 3, and 4 melanoma in terms of their chance of surviving this cancer. And so this figure that's shown on the left, it's called a Kaplan-Meier curve, where what we have is at the top, all of the patients are alive. And the question is over time, how many patients are alive with that stage of cancer? And so these lines are going down. That represents that over time, patients who were dying from the disease. And as a medical oncologist, the type of patients that I was taking care of the most at that point in time were patients with stage 4 melanoma, patients where the cancer had spread to distant places in the body. And back in 2007, when I started my career, the average survival for a patient with stage 4 melanoma was only about 6 months. And in a cancer that often affects patients who are young and very healthy, we're very fixated not only on the average survival, but how many patients can be long-term survivors. And in melanoma, that really, once you hit sort of 3 to 5 years, that's considered long-term survival at that time. And we were really only achieving that in about 5 to 10% of patients. And really, our treatments were very limited at that time. Dacarbazine was an FDA-approved chemotherapy that had about a 5% chance of shrinking the tumors, and usually only did that for a transient period of time. We were also really the first cancer to have an immunotherapy approved for the treatment of this cancer with high-dose interleukin 2. And that was a treatment that could actually cure about 5% of patients with stage 4 melanoma, but was so dangerous that 1 to 2% of patients would actually die from the treatment. So realistically, back at that time, the standard of care for patients with stage 4 melanoma was to go on to clinical trials because our FDA-approved therapies were really so poor. And so that's where we started out back in 2007 when I joined the faculty. And where are we in 2025? So we've had a complete revolution in the treatments that are available for patients with metastatic melanoma. So again, before 1998, we just had those two medicines, dacarbazine and high-dose IL-2, that were approved, neither of which had ever been shown to be better than another treatment. And from 1998 to 2011, we had no new treatments be approved for this disease. But really, and essentially, sort of the last 15 years, we've had 15 new medications that are approved for patients with stage 4 melanoma because they actually improve the survival of patients. And while in many cancers and historically in melanoma, we think about chemotherapy when we think about cancer treatments, melanoma was a complete paradigm shift. These treatments that have been approved are evenly split between targeted therapies, which are medicines that target the mutations that make a cancer cell different from a normal cell, and immune therapies that work by boosting your own immune system to fight the cancer. So none of the new medicines that we've had are chemotherapies. And so almost all of our patients who receive treatments are receiving immune therapies or targeted therapies. And some of these treatments are now also used in patients with stage 3 melanoma or stage 2 melanoma in that adjuvant setting where we're trying to prevent the cancer coming back. So let's talk just a little bit more about these different treatments that are our current FDA-approved therapies. So let's talk first about targeted therapies. So again, targeted therapies are medicines that target the cancer cells and directly kill them. So it's the medicine itself that's killing the cancer cells. And these are usually treatments that are targeting the proteins that are activated more in the cancer cells than they are in other cells in the body. And that usually happens because cancer has mutations where you take a normal gene and make it abnormal. So in melanoma, we know that approximately 40 to 50% of cutaneous melanomas have a mutation in the BRAF gene that takes the BRAF protein that we can normally turn on and off, and it's turned on all of the time. And for patients who have that BRAF mutation, we have 3 different FDA-approved targeted therapy combinations, and these are shown on the left. And one of the things I think that's important for helping you to understand is that when we develop these medicines, we work with the generic names of these treatments, but once they're approved, they then have commercial names. And so when you hear a doctor talking about dabrafenib and trametinib, commercially, that's Tafinlar and Mekinist. Vemurafenib and cobimetinib is Zelboraf and Cotellic. Encorafenib and binimetinib is Braftovi and Mektovi. These are just different names for the same medicine. And the hallmark of targeted therapies is that these work very fast and they work very well. So for a BRAF mutant patient with stage 4 melanoma, if we start them on targeted therapy, there's a 70% chance those tumors are going to shrink significantly, and really a 95% chance that we're going to be able to stop the growth of those tumors, at least for a while. And so these give very rapid benefit for patients, even with large tumors, and in the adjuvant setting, seem to be able to increase the number of patients who are cured by surgery. We do have some key challenges, though, and so for our BRAF mutant patients who are treated with these medicines, although these treatments work very well and very quickly, on average, they work for about 12 to 15 months, and 80% of the patients will develop resistance to these treatments at some point in time. And for patients who don't have a BRAF mutation, which again is a little bit more than half of our patients, we don't have any approved targeted therapy strategies. So as we talk about the improvements we've seen in overall survival in melanoma, we think a lot of that is due to immune therapies, and particularly the immune checkpoint inhibitors. And these were sort of developed conceptually by Dr. Jim Allison here at MD Anderson and Dr. Hanjo, who won the Nobel Prize for Medicine a few years ago for identifying this new strategy to attack cancer. And so this table shows you, again, those FDA-approved medicines we have: pembrolizumab, also known as Keytruda, nivolumab, also known as Opdivo, and ipilimumab, also known as Yervoy. And as you just heard, we sometimes combine these together, like the Ipi-Nivo combination, or our newest combination, relatlimab and nivolumab, known as Opdualag. And so our immune checkpoint inhibitors are antibodies that block receptors on immune cells that cancer cells utilize to turn down the immune system. And these are treatments that we give as intravenous infusions. And again, it's now not the medicine that attacks the cancer, it's your own immune system that attacks the cancer. And so what we've seen in patients with stage 4 cutaneous melanomas is that initially we had response rates of about 20% with Yervoy, now in the 50 to 60% range with the combination of Yervoy and Opdivo. And what's been so nice to see is that once the immune system learns how to attack the cancer, this is a benefit that can go on for years and years and years, even with only a short period of treatment. And so just to illustrate that, in 2025, we got the 10-year follow-up results from one of the biggest clinical trials we did in patients with stage 4 melanoma. Patients either got treated with ipilimumab or Yervoy, the nivolumab or Opdivo, or the combination of the two medicines. And again, to put it in context, historically, the average survival for patients with stage 4 melanoma was about half a year. And in this trial, the patients who were treated with Yervoy and Opdivo, the average survival was 6 years. And what's really to us most exciting is that when we look at the patients and how they're doing, 10 years after the start of treatment, 44% of patients treated with Opdivo were still alive and well, and 52% treated with Yervoy and Opdivo. And again, because so few patients have really had the disease come back if the treatment was working 3 years after the start of treatment, we think that those patients have actually been cured of their melanoma. There is a slight chance of the cancer coming back, and we still do surveillance, but overwhelmingly, if patients are doing well 3 years later, there's a very low risk that we measure in the low single digits that the cancer will come back. And so this again has been transformative to us, and it's really made a huge difference for our patients. And at the same time, we recognize that we still want to do better. And so first, although this says that about 50% of patients can be cured by immunotherapy, how do we cure the other 50%? You'll also hear today about the fact that immune therapies can cause side effects. And so how do we predict those side effects? How do we prevent those side effects? And then finally, probably the most pressing issue is how do we come up with treatments that work if immune checkpoint inhibitors don't work? And so that's really kind of the backdrop to the presentations you're going to hear about today. Dr. Ashley Holder is going to talk about the use of neoadjuvant therapy in our patients with stage 3 melanoma, why we do this, and how important and effective it is. Dr. Rhoda Amari is going to talk about our next wave of immune therapies that are not antibodies, but are actually immune cells. So she's going to talk about cellular immune therapy. Dr. Erez Baruch is going to talk about some exciting findings that have provided new insights in how our own diet and the microbiome can influence both the safety and efficacy of immunotherapy. And then finally, what's most exciting to me is to live in a world where we have long-term survivors of melanoma and a tremendous opportunity to really improve how we take care of these patients. And so Michelle Rolfs is going to talk about long-term survivorship with melanoma. So I hope that gives everyone just an idea of sort of where we are right now as we now move into these talks about what's new. And so with that, it's my pleasure to introduce our next speaker, Dr. Ashley Holder. And so Ashley is an associate professor of surgical oncology in the melanoma section here at the University of Texas MD Anderson. As an educator and mentor, Dr. Holder is program director and co-principal investigator of the NIH T32 grant in surgical oncology at MD Anderson, and she's a mentor to early career surgeons nationally through the Association for Academic Surgery, in which she currently serves as a treasurer. Ashley's actually done a lot of tremendous work and a lot of tremendous research, but I'm going to, for the sake of time, go ahead and stop sharing my screen so that Ashley can start her talk explaining to you what neoadjuvant therapy is and why we're so excited about this.
Thank you for inviting me and giving me the opportunity to speak with you all today. Are you able to see my slides okay? Great, thank you. So I have the pleasure of speaking with you about some of the exciting things as a surgeon with regards to a team approach to treating patients with melanoma. So I'll briefly touch on some of what Dr. Davis already did to reinforce what neoadjuvant therapy is and what are the pros and cons of that. I'll also touch on the current standard of care, and then I think some very exciting things that are on the horizon that have either developed over this past year or are in plans underway for the upcoming year. I'm a dog person. This is my dog, Louie, and so I've included him for a little bit of comic relief throughout because this is how he might look at the start of a talk, and hopefully I'll keep you all engaged and attentive throughout it. Neoadjuvant therapy specifically indicates cancer treatment that occurs before surgery. And you'll see in the images below, I've tried to display that immunotherapy will happen before surgery, but can also happen after surgery as well, almost in a perioperative approach. Or that it could be that patients have surgery first and then have immunotherapy afterwards. That's called an adjuvant approach. And when we use neoadjuvant therapy, that is with the intent that we are going to be able to remove any tumors that we can see on imaging or see on physical exam, so that the intent of surgery will be to remove all known sites. In other cancers, sometimes neoadjuvant therapy is used to shrink a tumor to make the surgery easier or the risk of complications less. That is usually not our goal in cutaneous melanoma. Sometimes with targeted therapy, we will do that, but typically with immunotherapy, we may or may not see a drastic change in the size of the tumor during the period of time we're giving the therapy prior to surgery. And as Dr. Davis mentioned, typically this approach is offered to patients that have stage 3 melanoma, so regional or lymphatic nodal metastasis, but it can be used sometimes in patients who have distant spread in a single site in their body. If you'll look back now, I've added a plus minus in that figure on the left, and that's because as we've learned more about neoadjuvant therapy and having the advantage of being able to look at the surgical specimen under the microscope and see how the tumor has responded to the therapy, we sometimes omit having any therapy after surgery as well. And just to reinforce, I do have it there as that sometimes the neoadjuvant approach continues into a perioperative approach. So you receive treatment both prior to and following surgery. So what are the pros and cons? And I'll say specifically that this is something that patients ask me a lot as a surgeon. Don't we just want to go ahead and get the tumor out? Why would you want to leave it in place? I feel like it could be spreading as we're waiting to do the operation. And there really are some advantages, and I hope that this will help make it clear as to why we think this approach is so beneficial and what clinical trials have shown. So one of the main advantages to doing this type of approach is that when we take out the specimen and the pathologist reviews it, they can look and see how much of the tumor is still alive to understand how effective your immune system was at killing the tumor. And if it's been really, really effective, you may not require any other therapy after surgery. And that's based on data showing that patients, in fact, continue to do very well, just as Dr. Davis mentioned earlier. It also helps us predict what your prognosis might be. So, what the outcome is likely based on the amount of response that your particular tumor has had to your body's own immune system, killing it with the help of immunotherapy. And then from a scientific perspective, we think the immune system is much more capable of causing a better response when the tumor is in place. And I will tell patients, think of this if I ask you to make me a purple dress, and I bet I'd get a lot of different looking dresses. But if I said, here, I've torn this picture of exactly the dress that I want, and this is the size and the measurements that I need, you'd be much more effective at making a dress that can fit. And that's similar to how your body can respond to immunotherapy when you're receiving it while the tumor is in place. Your body's own immune system is able to use the information about the tumor to make its response more effective. What are some of the disadvantages? There is a small chance that the tumor could grow and it could not be removed, but that's typically in cases where the immunotherapy hasn't been effective. It also does delay surgery, and patients can develop side effects or immunotherapy related toxicities that could make them unable to tolerate the surgery at all, rather than just delaying it for a period of time. Comparatively, only receiving therapy after surgery prevents that interval growth so that if the tumor is able to be removed now, that it can still be removed. It can prevent additional seeding to other sites if, in fact, your tumor is unresponsive to immunotherapy, and prevent delays due to immunotherapy related toxicities that might prevent you from getting to surgery. Some of the disadvantages, though, are that we think surgery itself likely causes immunosuppression and can alter response to immunotherapy. And by giving that immunotherapy prior to surgery, we're removing that variable from the equation. Another disadvantage is that immunotherapy might be delayed due to postoperative complications, and so you wouldn't receive that therapy right after surgery as planned. And that it's a delay in the treatment of the microscopic disease. So, as Dr. Davis mentioned, there could be disease in sites of the body that we can't even see on CAT scan or on PET scan. And in fact, by giving this whole body treatment prior to surgery, we're actually doing that before we even embark on the surgical resection. So, what is the current standard of care of neoadjuvant therapy? And hopefully, I haven't put you into a coma like my dog, you'll see here. I appreciate that your familiarity and that we do think of this in therapy typically with regards to numbers. So, monotherapy or a single agent tends to be nivolumab or pembrolizumab, as previously mentioned. And with combination therapy, typically that's nivolumab and ipilimumab or nivolumab and relatlimab. And I've highlighted in the bold lettering those therapies that are specifically preferred according to the National Cancer Consortium Network guidelines. And to focus on nivolumab and ipilimumab, that's been noted to have 64% of patients treated in this prior to surgery setting to demonstrate a major pathologic response. And what does that mean? It means that when the pathologist looks within your tumor or lymph nodes that contain tumor, they find that nearly all of the tumor cells are dead, or 90% or more of them are no longer alive. And we consider that a major pathologic response. And that, as a surgeon, I have to say, is the best news that I get to call and give a patient and say, we really got just the outcome we were hoping for. In this study, 78% of patients didn't have evidence of cancer recurrence at 2 years, and also that there were about 20% of patients that had more severe toxicities related to this immunotherapy. So the two drugs are very effective, but as you would expect with additional therapies, the risk of severe toxicities can also increase. There are some patients who can't tolerate immunotherapy. And then, although this is less common, we may consider intralesional therapies or those that are injected into the skin or the lymph nodes directly, often by a surgeon or by an interventional radiologist. And that's something like TVEC or Imlygic. Then sometimes we use targeted therapy in BRAF mutant patients, especially in the scenario that I mentioned earlier. So if the tumor looks like it's invading critical structures or abutting them so closely that we think there's a chance that we would have to do a vascular resection, for example, we would give something like this in advance because we tend to get a much quicker response and shrinking of the tumor than we do in immunotherapy. It doesn't mean that the immunotherapy isn't more effective in the long run, but sometimes from a surgical perspective, the BRAF mutant tumors respond better to those targeted therapies purely for the purpose of making the surgery easier. So some of the major questions being asked are which therapy is going to get us to that sweet spot of having a major pathologic response? And I wanted to share our data looking back in real time, and this has currently been accepted but not yet published, that in patients that we have managed, both with monotherapy, as you see in the middle bars, or with combination therapy, as you see in the bottom bars, or all patients, that we have a very good chance of ending up with a complete response pathologically. And I've put a little key in the bottom left. That means when the pathologist looked at representative sections, they did not find any live melanoma cells. That's the absolute best news, certainly, that I love to call and give patients, is that every bit of the tumor that the pathologist reviewed appeared to be dead. And so we see that with combination therapy, we can have that response in about 64% of our patients. Then a near complete response, which is combined with a complete response to be that MPR or major pathologic response, is about another 5% with the combination therapy. And you can see about 4% across all patients. And then with regards to partial response, that means that less than 50% of the tumor cells are still alive when the pathologist looks at representative sections. And that's the yellow bars you see. It's a smaller proportion, but somewhere in the 11 to 15% range, depending on which therapies. And then lastly, non-response. So that unfortunately means the tumor really didn't respond to therapy, and more than 50% of the cancer cells are still alive and viable. What you can see is with this approach, we have a lot of patients that end up having the majority or more than 90% of their tumor respond to the therapy and be killed effectively by our immune system. So, how does that help us decide about whether or not to give therapy after surgery or adjuvant therapy? You'll see two different studies. The one on the right is the one from our review of our patients at MD Anderson, and the one on the left is a study that was just presented this year at the European Society for Medical Oncology. And you can see in patients that they uh, studied, they did not give any therapy after a major pathologic response. So those are the two green curves. And you can see that in the complete response group, 95% of those patients were still alive after surgery without evidence of recurrence. And then you can see in the other green, about 70% didn't have any evidence of recurrence. In our data to the right, you'll see the blue is that complete response and the green is the near complete response. And those are still very high percentages of not having evidence of recurrence. That's about 90%. But in our case, about 70% of patients received immunotherapy after surgery and 6% received targeted therapy after surgery. So recognize we're not completely comparing apples to apples because on the group in the left, the green bars did not receive immunotherapy after surgery. And in the right, we do have some of those patients receiving therapy, and a large majority of the overall group of patients did. So now I have my dog looking really excited. He's engaged. He's maybe even smiling. And that's because I think the horizon for patients with melanoma and for neoadjuvant therapy is a really exciting and promising area. We're looking deeper into what tools may help us predict the pathologic response from studying the tumor. I can tell you this weekend, I'm actively working on a grant specifically focused on this question. Other groups have looked at whether the number of DNA changes or mutations in the tumor might help predict this. Also looking at particular immune checkpoints like PD-L1 expression, which is a control switch that slows down or turns off the immune response, and then also interferon gamma, which is a signal released by activated immune cells, and using that information to help guide which patients are likely to have that ideal response, and if we can determine that prior to even giving the therapy. And then other questions that are still being studied are which patients should receive therapy after surgery and which kind. We are leaning towards all but those who have had a complete response because we think there may be some long-term benefit for those patients. There's also studies looking at targeted therapy in patients that have BRAF mutant melanoma, and that appears to be possibly a little more effective than immunotherapy in the adjuvant setting. That's always weighing those risks and benefits of toxicities that come from therapies after surgery. And then another big question, and specifically around surgeons, is performing a targeted dissection or an index node dissection. And you might have heard some of that even in the layperson literature, which is can we remove just one lymph node if there was only one lymph node that ever appeared to be enlarged, and that was what was biopsied and confirmed the diagnosis, instead of removing all the lymph nodes? Why would we want to do that? Certainly because of an improved quality of life with decreased risk of lymphedema or permanent swelling in that extremity, wound complications, even a small risk of nerve damage associated with the operations that we do. This has been studied very preliminarily, and we think that if you were to have more than one lymph node, that it's about 88% likely to represent the response in the other lymph nodes if we just remove one of those. So it's relatively concordant, but not to the point where we feel comfortable yet with just removing that one lymph node. But there are multiple studies ongoing to help answer these questions effectively so that if we can downstage or reduce the extent of surgery, it would make this where the risks to the patient would be significantly less and fewer long-term effects of an operation, and potentially make this something where you would have this procedure and go home the same day. The last exciting thing I wanted to share is a large clinical trial that's going to be international. This is a randomized control trial, and this is led by a surgeon in Australia, specifically focused on patients who have stage 3 melanoma. And the goal is to aim to answer that question about removing all the lymph nodes or just the one lymph node deemed the index node and assessing the pathologic response. And if you look at the figure at the bottom, you can see that the patients would be randomized in that second box to either the lymph node dissection, which is the upper green box, or just the index lymph node, which is the bottom blue box. They would then receive the immunotherapy prior to surgery for 6 weeks. They would then undergo either the lymph node dissection in the upper arm, that green box, or just the index lymph node removal in the blue box. The pathologic response would then be assessed by the pathologist. We determine whether or not the patient has had a major pathologic response, meaning your immune system has killed 90% or more of the tumor, or not. If not, in the upper, patients would go on to receive adjuvant therapy or therapy after surgery. And you can see in the bottom that we would look and say, well, if they haven't had a major pathologic response, we would offer that bigger operation and the removal of all the lymph nodes. The goal is to look at the risk of recurrence in patients that have these different approaches at 2 years, and then also at survival at 10 years. Importantly, we're also asking questions about quality of life, since a smaller operation theoretically should lead to improved quality of life outcomes. So I'm really excited to see this trial be launched and ultimately have additional data to provide to patients so that we can determine what is the best surgical approach, both for their survival, but also for their quality of life, which is something we talk about frequently when we're looking at surgery. I hope that I haven't left you feeling like this, where you've now pulled up a pillow, but hopefully that you're excited about the promise of neoadjuvant therapy, which I really think there is. I'm happy to take questions about surgery or about neoadjuvant therapy. And thank you again for your time and attention. It's my privilege to be able to speak to you.
Very good. Ashley, thank you so much for doing this. And I don't see any questions in the Q&A box, but just to let everybody know, you can put questions in and Ashley will be happy to answer them. But, Ashley, again, as we talk about what's changed in melanoma, again, we often see this as a cancer where patients had a primary tumor and it's years later that a cancer comes back. And to me, this is one of the biggest changes I've seen over my career, because it used to be if patient had a melanoma and they detected a lump, the plan was go in and do surgery. Do you think that is still the approach right now, or do you think the standard of care is to do neoadjuvant treatment?
The standard of care is to do neoadjuvant treatment. So it's very disconcerting, I can imagine, as a patient to find something and you just want to have it removed. But hopefully, from some of what I shared, the recognition is that we know from studying this, patients do better and live longer if we give that therapy prior to surgery. And we get so much valuable information because we can see how your immune system has affected your particular tumor.
And I think one of the goals that we in the MRF have is, I have to say, I think within academic centers, I think it's recognized where we have multidisciplinary teams working together that this is the standard approach. And what I really hope is that this information makes it out broadly in the community as well, because it really is a change in how we treat this disease driven by new treatments and particularly new immune therapies. Thank you so much, Ashley. I'm going to go ahead and transition then to our next talk, which will be given by Dr. Rhoda Amaria. So Dr. Amaria is a longtime colleague of mine in the Department of Melanoma Medical Oncology, where she is professor, and she is also the director of clinical research for our group here at MD Anderson in melanoma since 2022. She is an internationally recognized clinical expert, both in patient care and in clinical research. And here within our group in particular, she leads our exciting program on adoptive cell therapy. Rhoda really has done this for many years and really, again, has helped to drive the field forward. So I'm really excited to have Dr. Amaria come and talk to us today about cellular immunotherapy for melanoma. And I will say that Rhoda is jumped out from rounding on the inpatient service. So Rhoda, thank you so much for joining us.
My pleasure, Mike. Happy to be here and present on one of my favorite things because I'm a super big nerd. I also have a dog named Louie. So, Ashley, another thing we've got in common. Okay, so here we go. Cell therapy. Yay. So, Let's talk a little bit about our T cells, because T cells are honestly the coolest cells that we have in our body. And the reason they're so important is because they have the ability to find and destroy melanoma. They also have the ability to find and destroy other cancers, but since we're really talking about melanoma and the responses are best in melanoma, we're focusing here. But there are many ways that we can make these T cells. And so traditionally, when we talk about immunotherapy for melanoma, we're talking about immune checkpoint inhibitors that Dr. Davis has already talked about. The ipilimumab, the nivolumab, the pembrolizumab, those are the traditional drugs. And the goal of those drugs is to very indirectly activate those T cells, make an army of T cell soldiers that then can hopefully go in, find melanoma, and destroy it. That's an indirect process. It takes some time to educate those T cells or make that T cell army. So it can take a little bit of time, and we know it's not universally successful. As Dr. Holder just talked about, there are intratumoral approaches, basically where you inject a medication into a tumor deposit to try to act as a stimulant and irritant to drive T cells into the tumor to recognize it and then destroy it. There are cytokines, which are basically T cell growth factors. These medications that when you give them can basically serve as a food for the T cells to make them activated, on alert, and hopefully, again, find and destroy melanoma. Or we could do a much more direct approach, which is actually take T cells out of a patient and either grow them, manipulate them, and then infuse them back. So those are the different kinds of ways that we can use T cells to treat melanoma. So if we focus specifically on T cells and how we get them and what we do with them, there are two main approaches. So if we take the approach on top, we've got our patient. We subject them to a surgery to remove a deposit of melanoma in the body. The reason why that would make sense is obviously it's good to remove deposits of melanoma if possible, but what we're really trying to do is find the T cells that are already driven into the tumor. Because remember, T cells have two things they need to do. They need to find melanoma and they destroy it. Well, if you take a tumor deposit out that already has T cells in there, you've relieved that first barrier because you have those T cells that have already recognized the tumor. So then what happens is after you have the surgery, that tumor basically gets cut up into little tiny pieces and sent. Basically, what you do is you take those T cells out of the tumor, and they get basically grown to vast quantities. You amplify. Say you start with a couple hundred T cells from the surgery. The whole process of manufacturing amplifies those T cells from potentially a couple hundred to potentially billions and billions. That's what TIL is, tumor infiltrating lymphocytes, because we're taking those T cells, those lymphocytes, out directly from a tumor deposit. There are things that can occur during the manufacturing. You could either have straight amplification of the T cells. You take those T cells and you just simply are replicating, and you're making billions of T cells. Or you can genetically manipulate those T cells to hopefully potentially make those T cells better. And so both of those approaches can occur in the manufacturing. We do have a standard of care TIL therapy called lifileucel or Amtagvi. And in that process, those T cells are simply amplified during the manufacturing. And that is now an FDA approved option for some of our patients with metastatic melanoma. So that's one approach to make T cells, but there's another approach to make T cells, which is called leukapheresis. So I think of leukapheresis as taking our patient, hooking them up to a machine that basically filters the components of the blood. And what we're specifically filtering out and collecting are our white blood cells, which include those T cells. Once those T cells are collected from this leukapheresis procedure, again, the cells are sent to the manufacturing facility where they can be genetically manipulated and amplified. And in this situation, when we're using leukapheresis for the starting material, we're generating either a T cell receptor therapy or a chimeric antigen receptor therapy. Now, neither of those approaches are FDA approved in melanoma yet. However, we are actively doing research with a T cell receptor therapy called IMA 203. This is something that's currently in clinical trials that some of you may have heard of. And again, that's where you take those T cells from the blood, send them to manufacturing, and the manufacturing basically makes T cells that are programmed to recognize a specific marker on the T cell on the tumor that's called PRAME. I don't really want to get into a lot of specifics there, but it's basically like you're engineering these T cells to recognize a little business card that the tumor is carrying around. Every tumor has these little different business cards. They're called tumor antigens, but in the specific example of a T cell receptor therapy that I'm talking about, that little business card is called PRAME. And PRAME is expressed almost universally on the surface of melanomas, whether it's skin melanomas or uveal melanomas. Most of them will express that little PRAME business card. So that's how we generate these T cells, either from the tumor or from the blood. But the end result is trying to manufacture billions of these T cells that are then frozen down and kept stored for you. Those T cells then get shipped back to the center where you're going to have the treatment, and then we get the treatment. So let's look specifically at the top where we're doing TIL. So we do have FDA-approved TIL therapy called lifileucel. It's specifically FDA for patients with metastatic melanoma that have previously received treatment with immunotherapy and have had exposure to BRAF inhibitors if they have a BRAF mutation. So we know those patients have already had their TIL manufactured, and those cells are frozen down and then shipped to the facility where you're going to have your treatment. At that point, we take our patient and we put them into the hospital to start on a heavy-duty chemotherapy regimen. This chemotherapy does not kill melanoma. It's specifically designed to deplete out our existing T cells that can serve as competition for the new T cells that have been manufactured. So patients get up to 7 days of chemotherapy to deplete out the existing T cells. Then the TIL is thawed out at the bedside and infused into the patient. And then we give high doses of IL-2. IL-2 is a cytokine. It's basically a T cell growth factor. It produces a friendly environment for those infused TIL to grow and thrive and be activated and go out and be ready to go and kill melanoma. And then after the 6 doses of IL-2 or up to 6 doses of IL-2, we allow the patients extra time in the hospital to recover from the chemotherapy, to recover from the IL-2, and basically get back into shape. That whole hospitalization takes generally 2 to 3 weeks. It's a pretty intensive thing to put patients through. But again, this is an FDA-approved treatment regimen. So this is how we treat people with the standard of care TIL. The TCR is very similar, but different. So right now, again, the TCR therapy, remember, is not FDA approved. It's only available on clinical trials that are being run here at MD Anderson and multiple centers actually across the world. And this is specifically for patients with metastatic melanoma that have had previous treatment and have a specific blood type called HLA-A0201. And part of that manufacturing of that T cell receptor is the T cell is being engineered to express PRAME, that little business card, on the tumor surface. And that binding between the T cell and the tumor can only happen if you have this specific HLA molecule. So for those patients with these specific characteristics, they have their leukapheresis, and then after the cells are manufactured, they come in and they get about 4 days of chemotherapy, that lymphodepleting chemotherapy, to deplete out their existing T cells. This chemotherapy is a little bit lower dose than the 7 days of chemotherapy that you get with the TIL. And because it's a lower dose, you can actually give this treatment outside of the hospital. So patients just come into the infusion center every day for 4 days. And then they get admitted to the hospital. They have the infusion of their TCR. And then in this clinical trial, they're getting up to 10 days of low dose IL-2 shots. So the idea here is you still need a cytokine to help those T cells expand, but we're using low doses of shots, IL-2, and then patients recover. And so this hospitalization should hopefully be a bit shorter than the TIL therapy, and in theory should be a little easier for patients to recover from because we're using lower doses of chemotherapy and lower doses of IL-2. So that's how patients are treated. Well, what are the side effects? Well, in both situations, whether you're getting TIL or TCR, you're getting chemotherapy to deplete out those T cells. But unfortunately, the chemotherapy can also reduce your red blood cells and your platelets. And so you have a risk of having decrease of all three of those blood counts. And that means that you have risk for infection because of depletion of your white blood cells. You might need blood or platelet transfusions due to depletion of your temporary depletion of your blood counts or platelets. And chemo in general can cause weakness and fatigue and poor appetite and nausea and hair loss as well. The cell infusion, whether you're getting TIL or TCR, generally is pretty well tolerated. Sometimes people can have some fevers and chills on the evening of the infusion. Sometimes people have like an allergic reaction temporarily, but again, usually these are pretty minimal side effects, and we're able to get people through the cell infusion without much toxicity. And then the IL-2 side effects are generally fevers, chills, fluid retention. This is especially true for that high-dose IL-2 that we give after lifileucel. Additionally, it can cause temporary damage to the heart and lungs. That's why we need to make sure patients can pass stress tests of the heart, lung function tests to make sure they're in good a shape as possible, because this high-dose IL-2 can be pretty toxic in patients, and it can cause some temporary organ dysfunction that improves across the course of treatment. The low-dose IL-2 can also cause some fevers and chills, fluid retention, but generally because these are shots and it's lower doses, patients generally tolerate it a bit better than the high-dose IL-2. So we've put people through all of this. We're talking about potentially weeks in the hospital. What's the efficacy? So we know that lifileucel was FDA approved based on clinical trial data suggesting about 30% of patients benefited. And when we look back at that initial group of patients, we see about 20% are actually surviving long term and doing really well long term. So again, a sign that these medications, these T cells, can really reprogram the immune system and provide long-term benefit. And also, I didn't really mention it, but the beauty of T cell therapy is that you get your treatment and you're done. You're not having to come back month after month and get an IV. It's a one-time treatment in the hospital, and then you're free to live your life. So again, this is an example that this pretty intensive therapy, if it works, can really work for a long period of time and be durably beneficial. The TCR therapy that I've talked about is not yet FDA approved. Clinical trials are ongoing. However, there's a lot of excitement because the preliminary data on the phase 1 trials suggested that about 50% of patients benefited. But we do have to acknowledge that right now this treatment is not widely available for every patient interested in trials. Right now, it's really for patients with either cutaneous or uveal melanoma. And again, you have to have that specific blood typing called an HLA-A0201, which we find in about 30 to 40% of Caucasians. So my conclusions here is that cell therapy is a really exciting treatment option. And right now we're really studying this in patients that have been previously treated with melanoma and need additional therapy. We do have to acknowledge that this treatment is complicated, it requires time in the hospital, and can definitely lead to some side effects. And it's not a good fit for every single patient. Patients really do need to be in good health and as fit as possible in order to get through this pretty toxic treatment in as good a shape as possible. So I will pause there. Thank you so much for your attention and for inviting me to talk today.
Rhoda, thank you so much for going over that. And one of the questions that, I think people are going to start to ask now that lifileucel has been approved by the FDA is I talked again about the immune checkpoint inhibitors, and you referred to them as well, which are FDA approved, and now the lifileucel is approved. So the question is, for a newly diagnosed melanoma patient, should they be getting immune checkpoint inhibitors or should they be getting TIL therapy with lifileucel?
I'm sorry, Mike, I am getting power paged. Just give me were you asking, were in the frontline setting or are you talking? Okay.
Correct.
Yeah. So I didn't mention that, but there is a clinical trial that is currently being done in patients in the frontline setting where there's a combination of giving lifileucel with pembrolizumab. And the initial data from that study seemed to suggest that the combination of these drugs was very effective, and could potentially provide high numbers of patients getting benefit. I agree that lifileucel can be an option in the front line, but I do really worry about the toxicity associated with this regimen. And again, acknowledge that it's not for everyone. My personal opinion is that we have immunotherapy combinations that are durably helping 40 to 50% of our patients with, I think, a much more manageable toxicity profile. So using those checkpoint inhibitors in the frontline setting, I think, should be a prerequisite for almost everybody. And I prefer to use cell therapy if my frontline immune checkpoint inhibitor didn't work. And that's simply, again, due to the toxicities. And there are absolutely people that get immune checkpoint inhibitors and can be, basically cured or have durable benefit without a lot of high-grade toxicity just from getting checkpoint inhibitors. So I think that should still be the way we treat patients. But there is a trial ongoing using lifileucel in the frontline setting.
Thank you. One other question, because lifileucel just got approved. This is a brand new treatment, and a lot of the questions I get from patients are about if this works, how long can it work? You and I know that we've been doing TIL trials for a couple of decades. So could you talk a little bit about what we know about how long these treatments can work?
Yeah, so back when we started the TIL program at MD Anderson, I think I was still maybe in medical school back then, but back when that had started, there were people that were treated that are cured. I still see them in my clinic once a year. And we think their melanoma is essentially cured. But that was back when we didn't really have a lot of good treatments for melanoma. We just had chemotherapy or high dose IL-2, which really weren't great treatments. Now, melanoma is treated very differently, and basically everybody's getting immune checkpoint inhibitor. And so when people are getting immune checkpoint inhibitor and are already immunotherapy exposed, we're unfortunately not curing as many people as we did back in the day. So back before we had checkpoint inhibitors, I would say probably 40 to 50% of patients getting TIL were durably benefiting. Nowadays, because people are getting checkpoint inhibitors, which I think, again, are incredibly important, that efficacy rate has fallen from 40 to 50% of people getting durable benefit down to about 20% getting durable benefit in this sort of modern era of melanoma.
Very good. Well, Rhoda, we again thank you so much for joining us, even though you're rounding in the hospital, and thank you for sharing sort of your long-term experience and expertise. All right, we're going to move on to our next speaker, and this is actually one of our newest faculty member here at MD Anderson in the Department of Melanoma Medical Oncology. I'm very proud to introduce Dr. Arez Baruch, who is an assistant professor in the Department of Melanoma Medical Oncology. Arez is a physician scientist, and he earned his MD and PhD in immunology from the Tel Aviv University in Israel. And I will tell you that even during his training, he did cutting edge work on the role of how we overcome immunotherapy by modulating the microbiome with FMT, leading to high impact publications that we across the world read and learned from. We were so excited when he came to Houston, came to our fellowship program, and has joined our faculty. And he's going to talk today about a really exciting new area of research, which is how does the diet and the microbiome affect both the effectiveness and the safety of immune therapy? So, Arez, thank you so much for joining us this morning.
Of course, thanks so much for the invitation, Dr. Davis. I hope that everyone can hear me, and let me share the slides. Just a second. Am I in presenter mode? Okay.
You are. It looks great, and you're coming through clear.
Okay, great. So, good morning / almost afternoon. The topic of microbiome and the cancer microbiome is a very hot and fast-growing field in cancer. There is a lot of applications, but it's also not that straightforward as sometimes it may come across when you run a simple ChatGPT question about what is microbiome. So the idea today is to give the basics, and other than the basic, what we and as patients can do, and what we as physicians are doing to sort of harness the power of the microbiome to help make the immunotherapy more effective. So let's just a second start with the basics. So what is microbiome? The actual scientific phrase is not microbiome, it's microbiota. And the definition is this is an ecological community of commensal, symbiotic, and pathogenic microorganisms that share a space in our body. And that can be any space. The most common is on the skin and on the gut. These are mainly spaces that are in touch with the outside environment. The largest by mass and also by number of cells, the largest microbiota mass lies in the gut. Microbiome is basically how we measure the microbiota, because it's basically the genome of bacteria in a specific environment or in a specific organ, and we are sequencing the genes of these bacteria, and this is how we're assessing or profiling what different type of bacteria are there. And over time, microbiome just took over as the general phrase, and everybody uses that instead of the old microbiota term. So how do you actually get microbiome? This is not an infection. This is not something that you catch, get antibiotic, and get rid of. It's a colonization process that basically starts from the day or from the minute we're out in this world, out of the womb, and being exposed to the outside environment. And the most critical period for establishing the microbiome composition is early childhood, birth to age 5. And there are many, many factors affecting the composition of the microbiome. The main one are what diet the babies and the toddlers are having. There is an association with lactation. There's actually a lot of publications related to that. Our genetics, because sometimes our body rejects certain bacteria but embrace other bacteria. Geography and climate, which is also associated to the diet that we eat in different climate areas and different geography. And exposure, for example, pets are very good in introducing different bacteria, as everybody who recently tried to clean up a dog probably knows. In adult life, the microbiome is actually mostly stable, and it's pretty hard to change in an effective way the microbiome. There are some shifts, especially right after antibiotic use. If you have surgery in the gastrointestinal tract, in the digestive tract, and the bowel is shorter or the stomach is shorter, it does affect long-term the microbiome. That one of the things that can change over time in an effective way, the adult microbiome, is changes in lifestyle, mainly physical activity and diet. And we're going to circle back to diet at the end. And the microbiome starts changing again, becoming more variable in older adults, mainly after the age of 65 and a bit older than that, with some slight degrees in how many different type of bacteria are living in our gut. Why do we actually need microbiome, and what is this all fuss about this field? So the bottom line is that the presence of the gut microbiome gives us benefits as humans, because the gut microbiome does a lot of stuff for us. The bacteria in the gut can take food that we as humans cannot digest, and they break it into pieces that we can use for energy. Those bacteria can produce vitamins for us. They protect us from infection. Just by their present, they're just not letting infection to grow because the gut is already populated with a lot of good bacteria, but also they can directly fight other bad bacteria or infections that are coming into our body. And over time, over evolution, they develop this very complex process and interaction, and they affect our nervous system. They are related to also to mood disorders like depression and anxiety. They can participate in how our body metabolizes, especially sugars and fats, and they also associate with how our immune system works. So if you try to remember the basic biology class in high school, what we were always taught is that the role of the immune system is to kill every non-human cell that is coming into the body, specifically to kill bacteria. Well, yes, but no. In the context of gut microbiome, we also want to benefit from the presence of the gut microbiome. So the role of the immune system in the gut is sort of like dilute and keep order. The immune system doesn't want that the bacteria cross into the human side. They want to keep the bacteria inside this tube that is called the digestive tract, but also don't want to kill too many bacteria, because then we're losing all of the benefits that the bacteria produce to us. And this interaction, again, happens from birth, over time, all day long. And over the many, many years of human development, this interaction is started to also shape the immune system. So not only the immune system shaping the composition of the gut microbiome, also the presence of gut microbiome change our immune system to the fact that we need gut microbiome to develop our immune system, especially the part of the immune system that is in charge on fighting cancers. And we know that because when we take animals and grow them in the lab in germ-free conditions where they don't have microbiome, they have significantly less effective immune system. And again, especially the adoptive compartment and the T cell compartment that are spearheading the fight against cancer. What we know today is that there are clear differences between the microbiome compositions of melanoma patients who responded to immunotherapy and those who did not. And that was established around 2017, 2019 by a series of science publications that also came from MD Anderson and were led by Jen Wargo. And the question is, what can we change, or can we change the gut microbiome to support the immune system and improve the effectiveness of immunotherapy? So there are several ways that we can effectively change the gut microbiome. There are more ways than what I'm going to present, but these are the highlights and the main ways. And this is dependent on, I would say, like philosophical beliefs or perceptions of different groups around the world. So one perception, and this was a dominant paradigm early on in the days of the gut microbiome in cancer, is that there is one bug that rules them all. We just need to find what is the dominant bacteria, make a probiotic drug that contains a lot of these bacteria, and then once we give it, the patients are going to respond way better to immunotherapy. And we're going to touch base on that in a second. Another idea is that we can't have one dominant bacteria, but we need a group of dominant bacteria, that these the group of bacteria as part of an agent that contains several bacteria, that is, the scientific name is a consortia, they can dictate and push the entire microbiome composition into being good. And the last perspective is that we need a net community effect of all of the bacteria, the viruses, parasites, fungi, whatever is in the microbiome. Everything sums up into a net effect or a net vector that push our immune system and make it better, make it more effective in the fight of cancer. And to change the entire community, we need a more drastic change than just taking one pill. So it's either changing the diet long-term or doing something that is called fecal transplant. And we're going to quickly go through the different ways of changing the gut microbiome. So probiotics were very promising in the beginning, but then we find out a few problems. One of them is which bacteria is the right one, which bacteria is the dominant. And the results from multiple cancer centers that establish the differences between responders and non-responders to immunotherapy. Each center showed that there is a clear difference between the patient who responded and the patient who non-responded, but each center also suggested a different type of bacteria. And the results were summarized with this very, very nice plot. As an insight tip, every time you see a very complex, fancy figure in a scientific paper, it means that the scientists don't really know what's going on, because otherwise this will be a way more straightforward figure. So that's problem number one. We don't know exactly what to produce. Problem number two is something that's called engraftment. Engraftment is the ability of outside bacteria or outside the microbiome to get into our gut and stay in our gut, meaning to colonize a new human or a new person. There are very big problems with engraftment in the setting of probiotics. The main challenge is that most bacteria just die in the stomach when we swallow the agent that contains the probiotics. And in analysis of many randomized probiotic trials, we see that the engraftment doesn't happen in many of the patients. And when it does happen, it's only very specific bacteria that survive. And since we have a very small amount of bacteria that survive and we take them all the time, that actually breaks the equilibrium in our gut microbiome. And one of the most important things in the context of gut microbiome and the immune system is to have a biodiverse or a lot of different bacteria that are in equilibrium, that they are balancing each other. And when you break this equilibrium, you weaken the immune system. And analyses that were done here at MD Anderson by Jen Wargo and Jen McQuaid and Christine Spencer, also published in Science in 2021, showed that patients who are taking probiotics actually have a lower response to immunotherapy. And we recommend to our patients in the clinic not to take probiotics, especially not around the beginning of their immunotherapy treatment. Another option is to do fecal microbiota transplantations, or FMT. This is something that I did my PhD on back in Israel. We enrolled patients into a clinical trial, patients with melanoma, metastatic melanoma, who failed anti-PD-1 therapy before. We gave them antibiotics, and then we did fecal transplant in two ways. One of them was through colonoscopy, and the other way was through what is called non-scientifically poopsticles, but these are basically capsules that are containing poop from a donor. They're fairly big, but they're also frozen, and somehow patients swallow them pretty easily. When you use those stool capsules in the purpose of FMT, you do need to swallow quite a lot of them, between 10 to 20. So not that easy of a procedure, but we did that, and we repeated the FMT using capsules every 2 weeks, every time the patient got Opdivo. And let me just share the results of one patient. So this is a patient who had multiple metastatic sites in the leg and in the inguinal. This is a PET CT, and the black dots are the patient cancer. And then a little bit more than 2 months after the treatment, we thought by imaging that the patient was progressing, but he was feeling so much better. So we took biopsies, and what we saw before the treatment is that there was pure cancer, but here we see a lot of brown cells, and these are lymphocytes that are basically eating up the cancer. And long-term, the patient turned from metastatic, who had a disease that was resistant to immunotherapy, became a complete responder. He is still in complete response today, almost 5.5 years after the treatment. He became donor himself and induced response in another patient down the road as the trial continued. So the FMT trials didn't enroll a lot of patients. It's a pretty complicated procedure, but overall in the publication and in the clinical trial that we did, we had 10 patients. 3 of them had objective responses per imaging, and similar results was from another FMT trial that was done independently in Pittsburgh University. The active areas of research is how can we mass produce this treatment? Obviously, taking poop from one patient and shoving it into another patient, it's a pretty barbaric thing to do in 2025, 2026. So we're trying to do it more effective and less poopy. And the other question is, what is the mechanism that is driving the FMT effect on the immune system? We are doing it a lot, specifically here at MD Anderson. This is an NBC News article that was published in another FMT clinical trial that we did for patients with colon and small bowel cancers. And one of the patients who also became a complete responder was sharing his story over there. What you can do as patient is changing the diet. What we learned over time, and these are again efforts that were led by Jen McQuaid, Jen Wargo, and Christine Spencer, is that increase, and Carrie Daniels, it's that increased daily fiber intake is associated with better chances of responding to immunotherapy. We're recommending between 30 to 50 grams of fibers per day. 50 grams can be a lot. This is a very basic ChatGPT image that I generated a few days ago. But basically, the leading sources of high fibers are beans, avocado, and broccoli. 50 grams can cause some bloating. Not everybody can tolerate 50 grams of fibers, but at least 20 should give a basis for the microbiome to stabilize and help the immune system to fight cancer. In general, tips of diet that we recommend for patients is eat more chicken and fish over red meat, moderation in sugar intake, so no more than 9 teaspoons of sugar per day, and that includes honey, maple syrup you put in your cereals, etc. But you also don't need to go to the extreme. There is no evidence that completely avoiding sugar of any type is going to starve the cancer or help the immune system whatsoever. The key in diet, just like in microbiome, is to have a moderate, diverse, and balanced diet. So in summary, the gut microbiome is sort of an outsider organ that is very critical to the development and activity of our immune system, and also control a lot of other systems in our body. A non-healthy or bad microbiome is associated with less effective immune system, and in the case of cancer, lower effectiveness of immunotherapy. We are able to modulate the gut microbiome to enhance immunotherapy efficacy. There are 3 main ways that so far the most effective one is the fecal transplant and the diet, not that many clinical evidence of probiotics. And our diet recommendation is 30 to 50 grams per day. I mainly want to take 2 patients that many people in the world know what genome or what genes are in their poop, but not a lot of people know who they are. These are our 2 donors from our Science FMT publication and the clinical trial I did back in my PhD, and they have a huge part in the success of the trial. They were involved basically from day one, affecting the design, helping us to build the pipeline. So huge thanks for them, and also both of them help patients down the road. And also like to acknowledge many people. This doing microbiome studies is a very complex and requires expertise from many different disciplines. So thank everybody, our collaborators in the States and outside in Israel, and especially to Jen Wargo, Jen McQuaid, and Carrie Daniel, and Nadim Ajami, who are helping me work on this at MD Anderson. Happy to answer any question.
Very good, Erez. Thank you so much. That was a wonderful explanation about what we've been learning about the microbiome and diet. And again, I think the takeaway that again is so interesting is this idea, because we often have patients ask us, what can I do to help myself to survive melanoma, to make my treatments work better? And the fact that we now actually have something in terms of what we eat may impact that, I think is really one of the important take-home messages. I think one of the other things that's really interesting about this, Erez, is also, I don't think you talked about this too much, but the potential effects that antibiotics can have and why we're so careful with antibiotics. Can you talk a little bit about the importance of antibiotics and the microbiome?
So antibiotics, again, it should be used wisely. When the concern about antibiotics is that just like using too much probiotics, you break the balance, because the antibiotics affect either specific type of bacteria, or if you get a large amount of broad spectrum antibiotics, like the sort of like the big guns antibiotics, it kills too many bacteria that we have in the gut, and that can also weaken our immune system. So let's start with the basic. If you need it, if you have a bad infection and if you need antibiotics, you should use the antibiotics because we have ways down the road to help the microbiome recover. So if needed, take the antibiotic. There is no rationale to avoid the antibiotic. Sometimes patients really pushing against and they become very, very sick, and we eventually need to use like a more aggressive antibiotics for a longer time. But also we need to be wise, just like you take your kid to pediatrician, and not every infection requires antibiotics. So I would say, especially in the beginning of the immunotherapy treatment, a month before up to 2 months later, this is the critical time when the microbiome kicks in. In that time period, I would be careful with using unnecessary antibiotic. But again, if needed, we should use it. And for example, Jen Wargo is working on very specific antibiotic regimens that target specifically the bad bacteria and using antibiotics to overcome cancer resistance to immunotherapy.
And just to relay that again in terms of for our patients, the challenge is that one of the most common side effects of immunotherapy is fever. And so this is where we often, again, when our patients get fevers, really are very careful about thinking about, does this mean patients have an infection and need antibiotics, or is this an effect of the immune therapy? And really, we just need to support patients through it. And so this is sort of why you hear when your doctors talk to you about fevers are a common side effect of immune therapy, and we don't automatically start antibiotics for everyone. But to Arez's point, we use them when they're needed. So Arez, thank you so much. We really appreciate it. All right, so our last speaker today is Michelle Rolfs, and having known Michelle for a long time, I'm contractually obligated to let you know that she obtained her Bachelor of Science in Community Health Education from Texas A&M University. And so she's a very proud Aggie, as I am a very proud Longhorn. Michelle's had a really interesting career. She actually started out working as a floor nurse on the melanoma floor here at MD Anderson. And after doing that for many years, decided to become an advanced practice provider within our melanoma team. And she's now actually the manager of all of our advanced practice providers. And, I think everybody here who's a patient or a doctor know how important the advanced practice providers are in the care of our patients. What Michelle also is the leader and the main care provider of our melanoma survivorship clinic. And so it's really exciting to be able to have Michelle come and talk to you today about what's something of a new entity and a new opportunity we have in melanoma, which is to optimize the care of our long-term survivors. So thank you for joining us, Michelle.
Thank you, Dr. Davis. Let me make sure that you can see my screen. Does it look good?
It's in the need to do the display settings to switch the mode. Yep, the swap.
All right.
Perfect. Okay.
Perfect. All right. Okay. Thank you. Thanks, Dr. Davis. And I'm excited to be able to talk about cancer survivorship. This is a topic near and dear to my heart, both professionally and personally. So in the next 10, 15 minutes or so, I want to talk a little bit about, what is cancer survivorship? What does this entail? And really, as you transition to the survivorship phase of your care, what is different? Because a survivorship clinic visit is going to look a lot different than the visits that you've been having with your oncology team. And I'll talk a little bit at the end about our specific survivorship clinic at MD Anderson and some available resources. So what is cancer survivorship? There's a lot of different definitions that you may hear about what survivorship is, and it's going to be different for individuals. It could mean, having no signs of cancer after finishing treatment, or, in some cases, you may still have some cancer, but it's stable and it's more of a chronic condition. But the more standard comprehensive definition is just living with, through, and beyond a cancer diagnosis. So survivorship begins at diagnosis and continues throughout the lifetime. And so for our survivorship clinics, although we acknowledge that survivorship begins at diagnosis, we are focusing on post-therapy and surveillance once you're off therapy and you have no evidence of disease. And most people have the common belief that life is different after cancer, and we acknowledge that, but you can go on to live a long, fulfilling life after having a cancer diagnosis and completing your therapy. So while this talk about survivorship, as you've heard today, our melanoma treatments have come a long way. And this is not just melanoma treatments, but if you look at cancer treatments along all different type of cancer, the treatments are getting better. We have a lot of survivors. According to the National Cancer Institute, as of May of this year, 2025, there are about 18.6 million survivors in the United States. That's a lot of people. And we acknowledge that these survivors, they need more of a comprehensive approach to their care. It's not just treating their disease, but there's a lot of different aspects, and we'll talk about that. And so melanoma specifically, we've talked about how our treatments have come a long way and they're successful. When I first started treating melanoma almost 3 decades ago, I'm dating myself, we did not have these treatments we have now. Dr. Amaria had talked about that. We had some chemotherapies, high-dose IL-2, and maybe in a handful of patients, they did well, but we did not have the success that we have now. And we never would have said somebody was cured of melanoma, but we are able to say that now. And we're seeing durable responses for many years. And so even if patients, like I had mentioned earlier, don't necessarily have a cure, but they have stable disease, that's still successful, and you can have stable disease for long periods of time. And like I said, these patients require more of a holistic approach to care, and we have specific goals in our survivorship clinics that we want to meet. So these are the main goals, and I'll talk about these individually on the next slide. But disease recurrence and surveillance is one of our main goals, of course. We know that we keep a close rein on our patients even after they complete therapy if we don't see any evidence of disease. So, in the oncology world, our goal is to treat the cancer, cure the cancer, hope it never comes back. But we want to make sure that we're doing the appropriate surveillance screenings, because if ever anything were to pop up, we want to be able to act on that quickly. But we don't want to get blinders and just think, whenever you're getting active therapy, we think melanoma, that's important, that's what we do. But there's a lot of other aspects that we can't ignore. So again, we follow the guidelines for melanoma surveillance, but we also focus on risk reduction, and that includes secondary cancer screenings. And like Murray had mentioned earlier, just because you've had one diagnosis of cancer doesn't mean you can't get develop another type of cancer. And risk reduction, including cardiovascular health, is very important. We're lucky. We have not seen any long-term effects on the heart from our immunotherapies, as opposed to some of the chemotherapies we used to give. So that's nice. Routine health maintenance is very important, as well as psychosocial needs and managing treatment toxicities and long-term effects from the treatment. So, disease recurrence and surveillance, like I said, we follow the recommendations for melanoma surveillance. And this is going to be dependent on what type of scans, will be dependent on what stage was your melanoma, where was your melanoma, whether we do PET scans, CT scans, ultrasounds, etc. But when you come to our survivorship clinic, you should have at least transitioned to every 6-month visits. As you know, when you're getting treatment or shortly after, we're seeing you quite frequently. By the time you get to this phase, you should be at about 6 months. And we keep you at 6 months for, the first 5 years. When you hit that 5-year mark, we can transition to annual visits. And then as you get closer to 10 years, we can start talking about pulling off some of those scans. And like I said, those scans will be dependent on your stage of melanoma and where it was. Regarding risk reduction and secondary cancer screenings, I hear it all the time, people say, I just figured you were checking for colon cancer. I've been coming every 3-4 months. I've been doing CT scans, but we know CT scans aren't the best for colon cancer screenings, for example. So we want to make sure that everybody is doing their secondary cancer screenings, and this is a big part of our clinic visit. So dermatology exams are the most important thing for all of our patients, and that's not just to pick up on any melanoma that may pop up, but other non-melanoma skin cancers like basal cell or squamous cell. So dermatology exams, we really stress with our patients. We also discuss all of the other age-appropriate secondary cancers. The more common ones for men and women are colorectal screenings beginning at the age of 45, lung cancer, especially in our smokers. We, for men, prostate cancer screenings beginning at the age of around 40, 45, and then breast cancer screenings with mammograms at 40 and cervical cancer screenings. So again, this is very important. I've had multiple patients over the last few years that had never had a mammogram or a prostate screening and have added these, and sure enough, they had a secondary cancer that they didn't know about. We were able to get them to the appropriate groups to treat these cancers. Again, it's all about early detection. Lifestyle factors, again, are very important. We focus on cardiovascular health, give a lot of education and materials regarding heart health. I always tell my patients it would be a shame to cure your melanoma, then you have a heart attack. We want to make sure that the heart is healthy. And again, we haven't seen any long-term effects on the heart from our treatments, but the most important things are, and as part of those wellness screenings, are cholesterol screenings, screenings for diabetes, etc. We talk a lot about healthy dieting and exercise, and again, we give a lot of information regarding that. We talk about tobacco cessation. We have our tobacco cessation program here at MD Anderson. And again, sun protection is very important for our patients. We really want our patients to have a primary care physician. A lot of our patients do not by the time they come to survivorship because, they've been seeing us so frequently, right? They don't have time or they don't, want to see another physician. But as we aren't seeing you as frequently, it's very important that you have a primary care provider to help with those wellness screenings and monitor you for heart disease and diabetes, bone health, things like that. We do discuss immunizations, and I know that immunizations are a personal preference, but we do educate on the current CDC recommendations. Psychosocial needs are very important, and I have a slide actually focusing on that next that we'll talk about, but really it's helping people return to normal day-to-day life. We do referrals as needed. And then treatment-induced toxicity and management is another focus in our clinic. The immunotherapy toxicities, the good thing is that by the time, you come to survivorship, you may not have, many, residual complaints, but we do have a lot of patients that still are dealing with lymphedema. They, I do referrals to physical therapy, to our surgical colleagues. Pain for some patients, especially if they had received chemotherapy in the past, they may still have some neuropathy. So we do referrals to our pain team. For patients that had brain metastases and received treatment specific to their brain, I do neurocognitive, or I refer for neurocognitive testing. As far as the immunotherapy toxicities, I work with our endocrine colleagues a lot. A lot of our patients have the hormonal imbalances that we're monitoring their thyroid panels. Some people may have residual joint pains, may refer to our rheumatology colleagues, neurology, etc. So specific to psychosocial needs, again, we know that and we acknowledge that a cancer diagnosis can be very life-altering. And we don't want to overlook that fact that it can be very taxing physically and mentally. And we really want to help focus on quality of life and getting you back to a point in your life that you can enjoy life and live a long, fruitful life. We do referrals. We have social work that helps. But it's stressful, employment, finances, getting back in the workforce, rebuilding relationships, and just that feeling of uncertainty about the future. Coping with fears of recurrence is a real thing. It's scan anxiety is real, and we acknowledge that, and I don't blame anybody for being so nervous about that, but we don't want it to be so crippling that you're not able to enjoy your life. And so really, helping and focusing on these psychosocial needs is quite important. So whenever I look at, I see my patients, there's really 8 domains, 8 areas of effective survivorship care, as mentioned here. And I do try to discuss all of these, and this is why it's more of a comprehensive visit and takes a little bit longer. But, like I had mentioned, the anxiety, depression, sleep, that's a big thing, back to those psychosocial concerns. Cognitive function, I had mentioned, I have referred quite a few patients for neurocognitive testing. Exercise, dieting is extremely important. I've done referrals to our nutritionists, physical therapy, infections and immunizations, I had mentioned, pain, sexual function. There's a lot of things that people are afraid to discuss, but these should be discussed at your visit, and you should be comfortable to ask your provider about these things. So one way we can make sure that we're identifying all of these needs and adding all of these elements is having individualized survivorship plans. I do give at the first visit, I give everybody their specific oncology treatment summary. It's going to have your personal patient information, who are your medical teams, what stage was your melanoma, where was it, what treatments did you get? Because surprisingly, people, especially if you've had a lot of treatments, it's easy to forget or know the dates that you had it. So that's something that a lot of people have appreciated. But we also talk about the follow-up appointments and tests, like I had mentioned, any long-term issues, emotional, social issues, and specific advice from the care team, as well as survivorship community resources. So these are just, again, some of the specific advice that we give as your survivorship team. Again, the screening tests and eating habits, exercise are a big things. Healthy weight programs. Like I said, we do a lot of referrals to our nutritionists. Sunscreen and overall sun health is extremely important for our patients. immunizations. I mentioned smoking and tobacco cessation, which is a big thing. And those that have continued to smoke, even after we've stopped doing CAT scans for their melanoma, for example, we may continue to do non-contrast CTs just to keep an eye on the lungs. Preventing osteoporosis is something that we discuss. Bone health is really important. All of our patients, we check a vitamin D level because we say don't go out in the sun, right? You get vitamin D from the sun. So we keep an eye on that. Any complementary alternative medicine, counseling, and like I said, we do referrals to our social worker is very helpful, or our psychiatry service. And then there's a lot of support groups as well. So specifically our survivorship clinic at MD Anderson. So we used to have a survivorship clinic many years ago and unfortunately had to get rid of it. It's more of a staffing issue and just the fact that we did not have many survivors. And, as we've been talking about all day, is that our patients are doing well. We're curing people of melanoma. So we really have a need for these survivorship clinics. And so we resumed this back in 2020, and it has ramped up significantly in the last 5 years. Our clinic is run by APPs, specifically myself, and then I have some others that help frequently. We had a clinic 1 day a week. We recently expanded to do 2 days a week, and hopefully within the next year expanding to more days. Again, just a testament to the need for survivorship clinics. So we like to see all of our patients in person, at least for the first visit. Again, dermatology exams are very important for our patients. So if you're seeing dermatology, one of our dermatology colleagues, then we can do occasional virtual visits, but it's very important that you are having great dermatology exams, including lymph node assessments. So our patients, because of the data that we have for our immunotherapy, our immune checkpoint inhibitors, we used to have our patients transition to survivorship at about 5 years, but because our patients are doing better and we know that, if they hit that 3-year mark, that we're seeing long-term responses, lifelong responses. So we can now transition our patients to survivorship at 3 years. So if you've had no evidence of disease, you started your last immunotherapy 3 years ago and have been off therapy for a year, then you are eligible for survivorship. And that's stage 3 or 4 melanoma patients. I will clump stage 2 patients in there because we do give some of our high-risk stage 2 patients, we do give adjuvant immunotherapy too. So we do, as on the medical side, see a lot of the stage 2 patients that historically had just been followed by our surgery colleagues. And lastly, I just wanted to throw this out, and there are a lot of community resources. Again, we acknowledge that, the survivorship domain, it's it's new and it's scary, and it's there's a lot that you're trying to take on, but there are a lot of resources. The American Cancer Society, cancer.net, Cancer Care. There's some great legal resources available. The National Coalition for Cancer Survivorship and Psychology Today, like I said, psychosocial is a very important aspect. So like I said, these are specific to survivorship and they're great resources. And so I will stop there for any questions.
Very good. Michelle, one quick question that's in the chat is asking specifically about how you're really monitoring for the long-term side effects from immunotherapy in the survivorship clinic. And particularly, are you using any like apps or e-health tools for this?
Actually, there are those tools available. I haven't personally used them. I will say the most common things that um, I'm watching for are the hormonal changes. We're monitoring thyroid plant panels and things like that. For those patients that have already had that they have the toxicities like the rheumatology, the joint pains and aches, a lot of them are still seeing rheumatology. Basically, it's just assessing them at every visit, asking those specific questions. We check organ function still. We're always checking, your kidney and liver numbers. So really just a good physical exam, a good, comprehensive labs, and looking, like I said, the hormonal things are the big things that we are watching for.
Very good. Well, listen, Michelle, thank you so much for going through that. And we're now at the end of the symposium. I really hope that this was something that people enjoyed. I think the take-home messages are we've come a long way in terms of our treatments for patients with melanoma, and we're fortunately in an era where more and more patients are now long-term survivors, even with stage 4 disease. We're seeing new paradigms of treatment, including neoadjuvant therapy for patients with stage 3 disease, doing things like interventions about diet and microbiome. And certainly the exciting new era that I think we're entering into, building upon what we had with immune checkpoint inhibitors, the new era of the cellular immunotherapies. And again, these are all areas where we made exciting advances in the past year. And I think we're all excited to see what will come in the future. So I hope that everybody enjoyed this and found it educational. Want to thank my colleagues who all joined us on a Saturday to give the talk, and thank again the Melanoma Research Foundation for your willingness to help and support patients. And we really appreciated the chance to be able to talk to patients today. So I'll hand it over to Debbie for her final remarks.
Thank you so much, Dr. Davis. What an excellent program you put together. Thank you so much. I'd really like to thank everyone for joining us today. Thank you to our sponsors once again for supporting us. With their support, we're able to put on events like this. Thank you to all the speakers from MD Anderson for presenting today, taking time out of their weekend. We appreciate all that you do for the melanoma community and appreciate you taking additional time to be with us this weekend. I just want to mention again, this program will be available on the MRF YouTube channel in a few weeks, and I will follow up with all of you with an email to let you know when that is available. I will also be sending out a post-event survey. I'll wait till Monday, let you enjoy the rest of the weekend, but would appreciate you taking just a few minutes to fill that out. It really does help us with future programs. And if you have any questions that you think of later, please feel free to email us at education@melanoma.org. Thank you for joining us, and I hope you all enjoy the rest of your weekend.
Thanks so much. Take care, everyone.